Hello everyone, my name is Aladdin Hamad. I'm a consultant radiologist. I work in BHR University Hospitals, East London in the UK. Today I'm going to talk about imaging of the adrenal glands. We'll talk a bit of anatomy first and then we'll go quickly through the different modalities: X-rays, ultrasound, CT scan, MRI and nuclear medicine. I'll try to emphasize on CT scan. Bit of anatomy first. The adrenal glands or the suprarenal glands are abdominal organs. They sit above the kidneys next to the spine. They have cholesterol, that's why they look yellowish. The right adrenal gland is pyramidal in shape and the left is semilunar and it's slightly larger than the right. The maximum thickness of the adrenal glands is 10 millimeters. Be aware of some variant anatomy, such as low-lying adrenal sign in cases of pelvic kidney. We can also have adrenal hypoplasia or agenesis, and we can have adrenal tissue in other organs, such as testicles. Horseshoe kidney is another variant we can see here in this example. The blood supply of the adrenal glands comes from 3 different arteries, and the venous drain goes to one vein on each side. This is a picture of the vascular anatomy of the adrenal glands. The lymphatics drain into the para-aortic lymph nodes, and the nerve supply comes from the celiac and splanchnic nerves. The adrenal gland has different layers with different functions, and different pathologies arises from these layers. Going through the modalities, we start with the X-ray, which is limited in adrenal gland pathologies. X-rays can show calcifications or mass effects. This is a long list of pathologies that can cause adrenal gland calcifications on X-ray. Please remember that metastasis can calcify, particularly from melanoma. This is an example of previous history of adrenal hemorrhage, calcifications on both sides of the spine. This is another example of hemorrhage, similar. This is previous hemorrhage in 1-year-old male in this age group. Consider, please, neuroblastoma in the differential diagnosis. This is a history of TB, bilateral adrenal calcifications. This is a calcific mass above the left kidney, which tend to be a hydated cyst on CT scan. This is a 6-year-old female patient with abdominal pain, left pleural effusion, and a questionable opacity in the left upper quadrant. Unfortunately, this tend to be adrenocortical carcinoma on CT scan. Neuroblastoma can be also seen as a mass with effect on the colon. This is another example of neuroblastoma with a mass effect on the right kidney. Sometimes you can see calcifications in rare pathologies, such as this case of calcifying fibrous pseudotumor. The second modality is the ultrasound, which is also limited, but it can has a role in pediatric population. Early in 2008, this paper was talking about good numbers of specificity and sensitivity and accuracy. But later on, of course, the CT scan was becoming the modality of choice. This is a normal appearance of the right adrenal gland. This is elongated adrenal gland on ultrasound in a case of pelvic kidney. Adrenal hemorrhage can be seen on ultrasound, such as in this case. And this is avascular complex lesion in adrenal hemorrhage. Adrenal hemorrhage can liquefy in the center, the fluid echogenicity, and they can be infected. This is a case of bilateral infected hematomas, and this is the needle aspiration. Adrenal masses can be seen on ultrasound as a hypoechoic lesions usually. This is an example of adrenal mass on ultrasound. This is a hypoechogenic pheochromocytoma. Another example of pheochromocytoma with possible internal echogenicities and possible calcifications. This is another pheochromocytoma with hypervascularity. This is a huge mass next to the liver, which was diagnosed pheochromocytoma with areas of cystic necrosis. Ultrasound can show cystic lesions as well, such as this example of lymphatic cyst. Adenoma can be also seen. This was confirmed on CT scan. This is another aldosteronoma. Not all nodules are masses, such as this example of nodular hyperplasia. This is the CT scan, and this is the nodule on ultrasound. Metastasis can be also seen. This is a huge mass in the right adrenal gland with a filling defect in the IVC, and this was metastasis from the lung CA. This is a case of TB with a pleural effusion. Addison disease with adrenal calcifications and shadowing. Contrast ultrasound, unlike the role of the contrast ultrasound in liver and kidney lesions, it has limited role in adrenal gland. These are some papers talking about the role of contrast enhanced ultrasound. This is example of pheochromocytoma on contrast enhanced ultrasound, peripheral enhancement and central necrosis. Third modality, which is the most important one, is the CT scan. The normal adrenal gland on CT scan is about 50 to 60 Hounsfield unit. The right adrenal gland is V-shaped and the left is Y-shaped. Hyperenhancement in the adrenal glands can happen in hypovolemic or shock hypotension complex. This is a case of a trauma with hyperenhancement of the adrenal glands. It could be non-traumatic, like this case in cardiac arrest, hyperenhancement of the adrenal glands bilaterally. Hemorrhage can be also seen on CT scan as a high density material in the adrenal gland in the acute and subacute phase, 50 to 90 Hounsfield unit. This is an example of right-sided adrenal hemorrhage. This is the subcutaneous emphysema from trauma. This is another more obvious example with high density in the adrenal gland. Hemorrhage can liquefy. This is an example in a neonate who had hemorrhage in the right adrenal gland and then turned to a pseudocyst. This is another example of high density of the adrenal gland with a obvious enlargement and no enhancement in the post-contrast images. It can be bilateral and in the context of sepsis in Waterhouse-Friderichsen syndrome. These are the adrenal glands with hemorrhage bilaterally, and this patient had liver metastasis as well. Adrenal cysts can be also seen on CT scan, different types of cysts. This is an example of pseudocyst, and this is epithelial cyst on the left side. Lymphangiomas can be also cystic lesions with peripheral calcifications, as you can see here. Cysts can be infected, as we said. This is a cystic lesion in the right adrenal gland with peripheral enhancement. Calcifications can happen in TB. This is an example of bilateral calcifications in TB, and this is another example of Addison disease, bilateral small calcifications. Solid masses on CT scan, they can be benign or malignant. Adenoma is the most common lesion detected on CT scan. This is a list of the benign lesions and malignant lesions. Adrenal adenoma on CT scan, often incidental, and it needs to be distinguished from metastasis. and 95% of adenomas are non-functioning. If the adenoma is hyperfunction, it can present with Cushing or Cone syndrome or sex hormone-related symptoms. Typically, adenomas are small, less than 3 centimeters. However, we can see atypical features such as hemorrhage, calcification, necrosis, and lipid-poor adenomas. 70% of adenomas contain significant intracellular fat. They are typically rapidly washing out, while non-adenomas tend to wash out more slowly. The protocol used to characterize adenomas is the 15 minutes protocol preferably. Some centers use 5 or 10 minutes protocol that includes the pre-contrast sequences, portovenous phase, and delayed phases. In a non-contrast imaging, anything less than 0 Hounsfield unit is considered 47% sensitive and 100% specific for adenomas. Less than 10 Hounsfield unit is considered 71% sensitive and 98% specific. This is the most important feature, which is the washout imaging. Anything above 60% absolute washout or more than 40% relative washout is diagnostic of adenomas. Please bear in mind that some hypervascular metastases can show identical washout, and if you see a Hounsfield unit of more than 120 Hounsfield units on the portal venous phase, so you should consider alternative diagnosis. This is a very important slide, an example of adenoma, and this is how we measure the washout. This is the formula here. You can calculate it and try to include as much as you can of the mass in the adrenal gland. So this is pre-contrast, venous phase, and delayed, and these are the calculations. As we said, anything above 60% absolute washout or above 40% relative washout is diagnostic of adenoma. Last year, there was a paper talking about an attempt of doing virtual non-contrast images. You give contrast and then you subtract it and avoid unnecessary extra radiation to the patients. This is an example of lipid-rich adenoma. This is the pre-contrast image with -5 Hounsfield unit. This is atypical adenoma, which can happen large mass with enhancement. Adenomas can be functioning, as we mentioned. This is Cushing syndrome with a large left adrenal adenoma. If aldosteronism is a clinical consideration, some centers are still doing adrenal venous sampling, as in this case here. This is the catheter in the right adrenal vein. Adrenal hyperplasia can be also functioning, like in this example, causing Cushing syndrome. And hyperplasia can be also associated with other conditions, such as thymic carcinoid tumor in this case. This is the thickened left adrenal gland, and this is the right thickened adrenal gland. Other less common benign lesions, such as myelolipoma, examples. This is a left-sided myelolipoma. This is right-sided extramedullary hematopoiesis, low-density central areas of a fluid density with a clue of splenomegaly and history of thalassemia. Myelolipoma can show similar appearances, but if you notice, the density in the center of this lesion is more fat rather than fluid. Myelolipoma can show calcifications in 25 to 30% of cases, like in this example here. More or less common cases, leiomyoma on the left side. Incidental hemangiomas can be also seen. This is not very common. This is another hemangioma with low density. And this is a left-sided ganglioneuroma in the left adrenal gland. Pheochromocytoma on CT scan, it's uncommon, and the clinical picture is more relevant and more useful in establishing the diagnosis rather than imaging. This is the rule of tens of phaeochromocytoma. A lot of you are familiar with this. So in 5 to 10% of phaeochromocytoma cases, there is underlying condition, and this is one example, which is mean 2 syndrome. Phaeochromocytoma is usually large, enhancing avidly, and it shows more enhancement on the portal venous phase rather than arterial. Any enhancement of 110 Hounsfield unit on the arterial phase is compatible with phaeochromocytoma, but this needs to be distinguished from hypervascular metastasis. Historically, there was a contraindication of giving iodinated contrast in cases of suspected phaeochromocytoma. Now this is not practiced anymore, and you can still give non-ionic iodinated contrast. If phaeochromocytoma is clinically suspected, biopsy is not recommended. This is an example of phaeochromocytoma with intense enhancement in the periphery on a portal venous phase. This is extra-adrenal gland mass, which was positive on MIBG in a patient who had hypertension, and this tend to be phaeochromocytoma. This is the ovoid lesion anterior to the left renal vein. Phaeochromocytoma can be calcified, like in this case, calcification in the center, necrosis, and intense peripheral enhancement. Adrenal malignancy on CT scan, the primary malignancy is rare. It can present with syndromes like Cushing syndrome if functioning. Imaging features, usually it's very huge, very big mass, and most are more than 6 centimeters. More than half of adrenal cortical carcinoma are stage 3 or 4, so it's aggressive primary. These are examples of a huge primary adrenal carcinoma. Adrenal malignancy on CT scan can be also metastasis. The most common primary comes from the lung, breast, gastric, liver, and pancreas. Usually metastases are bilateral, and they are for some reason more commonly seen on the left side. CT scan findings are non-specific. On pre-contrast CT scan, they are usually greater than 10 Hounsfield unit. They may calcify or show areas of hemorrhage, and typically they show irregular peripheral enhancement. This is an example of metastasis from lung cancer on the left side, and this is the needle CT guided biopsy. Metastasis from lung cancer, if you look at the portovenous phase here, this is the thin peripheral enhancement. If bilateral, adrenal lesions can be either metastasis or lymphoma. So you should consider lymphoma in your differential diagnosis if you see bilateral adrenal lesions. So the fourth modality is MRI. This is a document published in 2001 that concluded that chemical shift MRI is the most sensitive technique for differentiating adenomas from metastasis. However, recently CT is becoming more useful. And we only do now MRI if the CT scan results are equivocal or the contrast is contraindication. DW ADC images are not very helpful according to different studies. This is the standard protocol, and this is the most important sequence we use: gradient echo in phase and out of phase. Additional sequences can include DW ADC and post-contrast images. This is an example of how we measure the signal drop. It can be either visual, or you can calculate the adrenal to spleen ratio, or the signal intensity index of the adrenal gland to measure the signal drop so you can differentiate adenomas from other lesions. This is an example of indeterminate lesion on CT scan in a patient with breast cancer. This is in phase and this is out of phase image with signal drop, which is diagnostic of adenoma. This is another example of lipid poor adenoma, which still have some microscopic fat that can cause the chemical shift and the signal drop on the out of phase images. This is another example of metastasis in lung cancer. This is in phase and this is out of phase without signal drop. As you can see, the adrenal gland is still bright. MRI can be also helpful in characterizing benign lesions like cysts. This is a case of teratoma, different tissues. This is myelolipoma with predominantly fat content, and this is a case of pheochromocytoma. There are different pathways of dealing with adrenal lesions. This is a document from the American College of Radiology, which summarized that adrenal masses less than 1 centimeters do not require further investigation. This is a chart that explains the pathway of dealing with incidental mass more than 1 centimeter. This is a European document which was reviewed in 2016, which proposed 3 different scenarios to deal with. The first one, adrenal incidentaloma, the second, unilateral adrenal mass, and the third, adrenal mass in a patient with extraadrenal malignancy. So these are different pathways to characterize the lesions and determine what would be the next step to confirm the diagnosis. Modality number 5 is nuclear medicine. PET-CT scan is good and it can distinguish benign from malignant lesions in a sensitivity of 100%, specificity 87 to 97%. Of course, there's still some false positives and false negatives, and the uptake can be measured either visually or you can calculate the SUV. This is an example of adrenal metastasis on the right side with lymph node metastasis from, I think this was the lung cancer. This is another example of lung cancer. This is the primary in the right lung, brain metastasis on MRI, and peripheral uptake in right-sided adrenal metastasis. Pheochromocytoma has some specific agents used, and nuclear medicine in pheochromocytoma is useful but not very specific. It can be used to locate extraadrenal lesions, and these are different agents that are used. MIBG is still widely used, and this is an example of MIBG SPECT scan in a mean 2 syndrome with thyroid, medullary carcinoma, and bilateral pheochromocytomas. In summary, we noticed that X-ray and ultrasound are limited. Ultrasound can be used in children. CT is by far the modality of choice in characterizing adrenal lesions. MRI is becoming limited. Any adrenal lesion less than 1 centimeter do not require further investigation. If it's between 1 and 4 centimeters, CT scan adrenal protocol is required. Anything greater than 4 centimeters should raise the possibility of malignancy. Do not biopsy unless pheochromocytoma is ruled out. And be aware that hypervascular metastasis may show sometimes identical washout values similar to adenomas. And also be aware of the atypical features of adenoma. And this is my time. These are the references, and thank you very much.